welcome everyone to Let's Talk Dental. This is a BIOLASE webinar series, and we're excited to welcome Dr. Fred Barnett as our speaker. The lecture this evening is called It's Time to See the Light, an evidence-based overview of the mechanism and advantages of the Waterlase all-tissue laser in endodontics. As always, we are hosting tonight's webinar on the Zoom platform and welcome your questions during the lecture in the Q&A feature in the lower toolbar of your screen. And we will be sure to wrap up tonight's session with a few minutes to address audience questions with Dr. Barnett. So feel free to post your questions during the lecture. At the conclusion of the lecture and Q&A, I will provide information about BIOLASE education CE process, so you do get a CE credit for joining us, along with additional web resources you can access to continue your learning journey in laser dentistry, including upcoming webinars and courses you may want to consider. Actually, Dr. Barnett is instructing our next Waterlase Endo course in Dallas this summer, so I'll give you some information on that. Tonight's webinar is being recorded, and we do post these in our nice, robust webinar library in the coming days. You can find that library at education.biolase.com. So let's get started. Dr. Fred Barnett received his DMD degree in 1978 and his certificate in endodontics in 1981, both from the University of Pennsylvania School of Dental Medicine. He received his board certification in endodontics in 1988, has served as the director of postdoctoral endodontics at the University of Pennsylvania, and is currently the chairman and program director of the postdoctoral endodontic program at Albert Einstein Medical Center in Philadelphia. Dr. Barnett has written numerous scientific and clinical papers and has lectured nationally and internationally on the treatment of endodontic infections, revascularization, dental trauma, root resorption, and contemporary endodontic treatment. So Dr. Barnett, we're really excited to have you with us. Thank you so much for joining us, and I will pass it over to you, sir.
Okay, great. Thanks, Joe. Hi, everybody out there, Zoom land. So yeah, we're going to talk lasers. And what I'm hoping is that you kind of get a sense of how valuable this tool can be in the treatment of our everyday cases, non-surgical, retreats, as well as surgical. So we've been using these lasers, the I+ in particular, for over 4 years in my residency program. And this is now my 4th class of residents being trained on laser endodontics. All of them absolutely have seen the light. Actually, what they say is you cannot unsee how clean everything is. So we'll get going. Financial disclosure. Yep, I have empty pockets in a sense. I don't receive royalties for any product from any company. No consulting fees. I'm not on anybody's payroll. I'm actually happy when Einstein pays me twice a month. No stock options, no commission from sales. I do get an honorarium for lectures I give. So first question should be, why are we spending so much time and money actually on advanced irrigation devices, lasers, gentle wave, all these things? And basically, it's the question has to be, is there a problem in our endodontic outcomes that's looking for a solution, or do we have a solution that really is looking for a problem? Well, my point of view is that, yeah, we've had a problem in endodontics, especially in terms of outcome on teeth with apical periodontitis. And even beyond outcomes, if you kind of take a look at this picture right in the top, in the middle, the micro CT of the canal anatomy, it's crazy. How do we actually clean this? And are the really complex anatomies, are these the ones that we're having problems with getting apical periodontitis to heal? So it has been well established from the mid-1950s that the presence of a preoperative periapical lesion is the main prognostic factor for outcome, meaning a tooth has a lesion before we start, it immediately and automatically, let's say, has a 10 to 15% lower success rate than a similar tooth without periapical disease. And we certainly know for quite a while that apical periodontitis is a biofilm disease. And if you look at all these studies from the mid-50s and going as far back or recent as the Toronto studies from 2006, the brown bars, the brown vertical bars, are outcome of endo treatment with a healthy or normal periapical structure. The white bars are kind of the outcome on teeth with apical periodontitis or periapical disease. And what you clearly see from all of these studies, and there isn't one study that has it the opposite way, is that a tooth that starts with an apical periodontitis has a reduced success rate compared to the teeth without. So what's the problem? The problem is that we're kind of stuck with a biofilm in the canal system, and we just haven't been able to really improve the debridement and disinfection of the canal system to eradicate the biofilm. And certainly hoping that advanced irrigation, lasers, gentle wave, whatever, helps us with this. So just briefly, a biofilm is the stuff that's in the necrotic and infected canal. It's masses of different types of microorganisms. There's a whole array of different species in there, but it's also the bacteria, they're embedded in this extracellular polysaccharide matrix. It's kind of like a gooey, sticky substance that is very resistant to our irrigants as well as our intracanal medicaments. So one thing that we try to do is actually physically debride the biofilm, try to disrupt it, and then of course follow this up with a lot of irrigation. So we kind of know from many, many studies that our instruments maybe touch 45, 55% of the canal walls, but that's okay because we obviously don't need to touch all the walls to get success. So we have to think about irrigation is probably the most important aspect of our treatment once we've shaped the canals, right? So it's really going to be all about irrigation. What the preponderance of all evidence basically is suggesting that if we could improve the disinfection, kind of render canals not necessarily bacteria-free, but to kind of reduce the bioburden of what's going on in the canal system, this will lead to higher success. It's an indisputed fact. But when you kind of take a look at the two images on the right, the one on top is that micro CT picture with the complex anatomy that you see in red. And then the bottom is a periapical radiograph of a mandibular molar with a crown, apical periodontitis, with really insane curves. And it'll be like, yeah, I'm not looking forward to kind of trying to instrument this to patency. So how can we predictably, and can we, basically manage complex anatomies? Instruments will never do it. So basically, it's going to be left to irrigation and activation of irrigation. So we kind of ensure that hypochlorite, EDTA, chlorhexidine, whatever it is that you like to use, can kind of get down these canals, have contact with the biofilm, have contact with some of the colonies of microorganisms that are down there to kind of basically change the threshold level. And that's kind of what we're trying to do. So this kind of brings me to lasers, right? Lasers, acronym by Einstein, kind of the institution where I teach, light amplification by stimulated emission of radiation. So what's in the laser? What's in the box? There's a active medium, and so if we talk about an erbium YAG or an erbium chromium YSGG or an ND YAG, this is going to be the active medium. It could be solid state, it could be a gas. So when this active medium is stimulated either by light or electricity, photons are produced. And the photons are going to be a specific wavelength. So when we talk about the YSGG or erbium type lasers, they have a very specific wavelength. And that distinguishes the laser light from ordinary light. So laser beams, these are characteristically monochromatic, right? One color, they're unidirectional, coherent, and emitted from a stimulated active medium. So trying to understand some of the laser physics, yeah, it could be a little intimidating. I'm speaking from my experience. There are a lot of factors, and you kind of see this list, and I'm not going over any of this really, that can affect how the laser actually performs. So laser physics, yeah, we need to know some things. What's most important is that understanding has to help us better understand the reaction between the laser energy and the tissue that we're trying to have an effect on. So when we talk about laser activated irrigation, the substance that we're going to be putting the laser energy into is either going to be water or hypochlorite or EDTA. So this is going to be activation with laser energy of our irrigants. So you see there are two boxes on the bottom, both web addresses. Joe already talked about the biolaze.com. Lots of really good webinars that are on demand and free. The one on the lower right is the AALZ, seminar schedule. And this book, The Principles of Medical and Dental Lasers by Renee Franzen, this is a very easy book to read. And it doesn't seem like it would be, but it's kind of dumbed down for the non-physics people, which I put myself in. So that's a very easy read, inexpensive book, put it on Amazon. It kind of helps put some of these terms, right, into perspective, because again, we don't have to be a laser physicist to kind of use laser energy to our advantage. So this slide is kind of showing the difference between an ordinary light from a light bulb and the difference with a laser beam. And when I talked about monochromaticity, the light bulb, it's white light, has all different colors, all different wavelengths. The laser beam is going to be one wavelength, same time. The peaks and the troughs are going to be run in parallel. So that's going to be called coherent. So it's very different than ordinary light. And light is on the electromagnetic spectrum. Yeah, I'm sorry, I'm not going to spend much time on this. On the left will be gamma rays and your X-rays. So that's ionizing radiation. In the middle, you see the visible spectrum, right? All the colors. And then in that group will be some of the diode lasers. And then in the near to mid infrared range, you see the erbium, the ERCR YSGG, and on the bottom, the erbium YAG. So the YSGG is 2780 nanometers. That's the wavelength. The erbium YAG 2940. So they're pretty similar. And then you see just above that, a carbon dioxide laser is going to be kind of in the 9,000 to 10,000 nanometer range. So we basically kind of want to have a laser or choose a laser that has a wavelength specific to our needs. So in this laser tissue interactions, because this is going to be the most important thing, we want to have an understanding of how we can use this predictably and effectively, right, to kind of have an effect on whatever the target tissue is. And that's going to be basically when you match the wavelength of the laser with the tissue that can absorb that energy. And matching the wavelength to the target tissue basically is what a chromophore will tell us. So a chromophore is a molecule, it's in the cells and tissues that's responsible for its color, right? So the water lays, the erbium, chromium, YSGG, this is absorbed essentially by water. So our liquid irrigants, water in soft tissue, the water in bone, cementum, and dentin. You also see here that laser irradiation can be reflected off the surface. It could scatter in the tissues, and it could be transmitted through one tissue to have an effect on another. So this is a picture of kind of chromophores and what they absorb. So you kind of see the erbium right here with the red arrow. This peak is water. So if you kind of look at diodes, Nd:YAG, CO2, the peak of water absorption fits perfectly with erbium. And it's not just water or our irrigants, it's the water in gingiva, mucosa, bone, cementum, dentin. So we've been using this YSGG laser for gingivectomies, flap, incision for apicos, osteotomies, where we're kind of opening the bone, root resection. So again, it's the interaction between the wavelength that's coming from the machine and the target tissue that will be absorbing this laser energy. So transmission is very interesting. This is where laser energy will pass through one tissue to interact with another tissue. And what's the tissue that it will interact with? It will be whatever that tissue is, what the chromophores are, and that's how the wavelength was selected. So retinal surgery, right? That's an example. The laser passes through your eyeball. It goes to the retina because the retina has a different color than the lens of your eye. Because this happened to me several months ago. I had a torn retina, went to see a retinal surgeon. He kind of says, yeah, you ready to do this? Yep, let's do it. Do a one-step retinal repair, right? So they put some drops in your eye to numb it. They're shining a laser right through your eyeball, and it's not really doing any damage until it gets to the retina, where the retinal tissue, different color, absorbs that wavelength, and then that torn retina in my eye was kind of welded shut. So this is a perfect example of what my eyeball was like. The laser beam energy goes through the white or clear balloon, doesn't do anything. The target tissue was that orange or red balloon. So the wavelength of the laser matched perfectly to the chromophore of that orange balloon. So laser energy, it's either going to be absorbed by tissue, diffused in the tissue, and this will generate different types of effect. So one is going to be heat or photothermal, right? So this is the effect of direct laser energy on tissue. So especially if lasers are used dry, and any wavelength or all the wavelengths can produce some degree of heat or thermal effect, or on the far end, thermal damage. So again, we're using a water lase. We're never cutting dry. We're always going to be aiming at tissue to be ablated that contains water. And as we're using the YSGG laser, we're always using it with water spray, right? So this is really important. We're not looking for any photothermal negative effects. The other type of reaction is one that's called photochemical. So if you heard about photoactivated disinfection, this is kind of it's been around quite a while. There are some new devices coming to market. This is where after you like enlarge or shape a canal, you're going to kind of squirt in a dye, methylene blue or indocin green, and then you'll have a diode laser of a specific wavelength that will match the methylene blue or a green dye, and the fiber goes in the canal. The dye absorbs this photochemical energy, and that's supposed to destroy or ablate the biofilament bacteria that remained in the canal. And then the third one is going to be photomechanical or photoacoustic. So this is kind of what we're doing when we do laser activated irrigation, right? So again, the water peak fits perfectly with the erbium lasers So the liquid absorbs the energy, and what you'll have is a mechanical and acoustic cavitation, shock waves, shear forces, all these things, which are basically going to disrupt, the biofilm, any tissue that's kind of left behind. And this is going to be done without any direct irradiation or heat on the dentin or periapical tissues. So there's no heat that's being created above maybe 1 to 3 degrees C. So there's no negative effect of the heat with the right settings and the right technique. So the erbium lasers you kind of see here all the way on the left, this shows you a depth of penetration. So the erbium laser will kind of penetrate tissue. It's less than 0.5 millimeter. So if we're doing gingivectomy, for example, and yet we use the laser at the right setting with the right tip, we're going to be ablating the gingiva, right? The tissue that's kind of in the way. It's not all of a sudden one pass and the whole papilla is gone. You're basically kind of doing cell layer by cell layer. It's very precise. You see exactly what's happening. And again, we're using the YSGG wavelength, always with water spray. So we're avoiding any photothermal or heat damage to the tissue. So it's extremely, extremely safe. So that's very shallow penetration. And then on the right side of this picture, the diode and the Nd:YAG go much deeper, maybe 4 to 5 millimeters. So kind of cell layer by cell layer, very precise and extremely accurate, because you're watching kind of tissue being ablated. It's kind of an amazing thing to watch. There are a handful of laser tips we use, and again, it's going to be based on the procedure that we're performing. So end firing tips, that's this one here. This will be when we do gingivectomy, osteotomy. There are some we use incision. So hard and soft tissue, these are great, extremely effective, and actually very efficient. Then in the middle, we have these radial firing tips. And these are perfect for laser activated irrigation. So the periodontists have been using these for diseased perio pockets to kind of blast out biofilm that's on the root surface. And then we use this side firing tip here on the right, has been used by periodontists to kind of decontaminate or kind of blast off, if you will, the biofilm that's on the peri-implantitis cases. And we've been using this root end side firing tip to kind of decontaminate the surface of the root end when we complete the root resection. And then so the radial firing tips, right? Again, perio and perfect for the root canal. These tips are 100% radial firing. There's no end firing. So it's not like shooting energy in an apical direction. You kind of see from this picture about how it kind of radiates from the tip. So, and again, we're not using direct irradiation on the tissue. This is always going to be done in a cushion or volume of water. And you can kind of see this on this picture here. So laser activated irrigation, you can say it's all about the bubbles. And I was talking with somebody at the AE meeting, and they kind of came out with the statement, yeah, you're scrubbing bubbles. And I go, well, kind of in a way. So what you see up here, starting on the top left, so there's a laser tip. Now, there's the laser fired one pulse, and what happens is the liquid, the molecule, is going to begin to expand. So this is the creation of a vapor bubble. And the vapor bubble gets bigger and bigger and bigger. It can't just keep expanding forever. Then it will implode. And as soon as the first laser pulse is fired, we have shock waves being created in the liquid, in the canal. And then when the bubble implodes, this is the cavitation effect. This will cause acoustic streaming, shear forces, jetting of the liquid. And basically, it's to kind of disrupt the biofilm, disrupt any of the necrotic tissue. So we're activating liquid to kind of do all these things for us in the canal. And I'll show you a couple of videos of how this is. So these are obviously not root canals, but they're glass, they're transparent, so you could see them. They're filled with kind of a hydrogel, which is going to be a gooey substance, kind of to mimic biofilm. And on the top, the 0 seconds, this is before the first bubble begins to expand. What you see here with these yellow arrows is that the first laser pulse, an initial shock wave is created. So you already see disruption of this hydrogel, this biofilm, right? And it's beginning to kind of disrupt, activate, agitate the contents of the canal, let's say during our final irrigation. And then over a period of time, the bubble expands, it will eventually collapse or implode, and that creates secondary cavitations, this streaming, shear forces, and it's kind of been talked about how this even can create some negative apical pressure. And I'll show you a little bit of this. So when you cause the first initial shock wave and then the expansion and then implosion of the bubble, it creates this volumetric oscillation of liquid, very fast vertical movement. The contents of the canal are going to be kind of traveling coronally. And again, hopefully it's to disrupt the biofilm that's so hard to remove, detachment of these microbial colonies, and then displace all this stuff out towards the chamber. So this paper is only a couple years old. It was written to basically explain the working mechanism of what is laser activated irrigation and its action on hydrogel or microbial biofilm. So these are high-speed imaging studies. The clip on the left, right, it's this root canal model. It's tapered like a canal, let's say, can be after shaping. You're going to see one single pulse. So you're going to be looking at this tip of the laser tip. It's right at the orifice. And when I play this, you're going to see an expansion of this bubble and then implosion. But this look down here, you're going to see a shock wave is created before the first cavitation bubble is created. And you'll kind of see this coronal displacement of the hydrogel. The bubble's expanding. You already see movement down the canal. This is a shock wave. And then when that bubble implodes, secondary cavitation, more shock waves, shear forces, all designed to kind of activate, agitate the stuff in the canals and have it go coronally. Now, this tapered canal on the right that's filled with the same hydrogel, you're going to see a cycle of 20 seconds. It's sped up, right? You're not going to watch this for 20 seconds, but you're going to see the same thing. You're going to see initial shock wave. You're going to see displacement or agitation of the contents of this tapered canal. And what we've been doing is we do cycles of 30 seconds. This study used laser cycle of 20 seconds. We've been using 30 seconds per canal with hypochlorite, and then 30 seconds EDTA, then 30 seconds with more hypochlorite, and then a final rinse. And then, so also take note of where the laser tip is. It's like right in the orifice. So when you bring that laser tip further down the canal, let's say mid-root or the coronal third, you get a significantly greater activity because most of the energy that's coming from the firing of the laser pulse is closest to the tip. The further away you are from the tip of your laser fiber, the energy will dissipate. So let's take a look at this. So this is sped up. It's going to show 20-second cycle. It doesn't blast it out in 2 seconds. When we bring the laser tip deeper in the canal, you clearly will have a more effective and efficient debridement of this. So that this is a 20-second cycle. As I mentioned, we do cycles of 30 seconds when we're doing actual treatment. So again, this is a 3D printed tooth. It's filled, the canals are filled with a blue dye. This is a radial firing tip, the 200 micron, which is the size of a size 20 hand file. I'm going to play this again. So you're going to see the fiber is kind of being brought pretty far, or pretty close rather, to the working length. It's going to be activated as you withdraw. So it's kind of a little bit snug. There's not a lot of room around it. Watch what happens when the fiber is being withdrawn, and it's going to be kind of where I put this yellow arrow. Look at what happens to the blue dye when that happens. So the fiber is now in the apical portion. It's being activated, withdrawn, and now when it gets to a wider part of the canal, you get a tremendous activity, cavitation, shock waves, shear forces, where it's really facilitating the removal, the debridement of what's ever left in the canal. So we do this step when we're done with the instrumentation. And I'll go through a very specific protocol. So this is not a tapered canal. This is a parallel cylinder. There's a little bit of gelatin that you see here, this simulated apex. The laser tip is being activated on the way out. So what you see that's bright, that's the aiming beam. So you'll see, you'll hear in second and see, now it's going to be activated, right? So you're seeing the bubbles, and it's not kind of extruding liquid or breaking up this simulated apex. So we kind of, and I'll show you some studies where we're not extruding irrigant past the apical foramen. That's not anything anybody does. And this paper by Martin et al. Talked about how when you activate on the way out, you can actually cause some negative apical pressure. So this video clip, this is actually kind of one of my favorites. So this was probably the first week we have the laser. One of my second-year residents completed all the instrumentation, the irrigation on this premolar, right? So what we were using before lasers were, we were using passive ultrasonic activation, right? So we would activate with the IRISafe tip, we'd bring the tip to within 2 millimeters, activate with the ultrasonic with hypo, EDTA hypo. So this resident, right, he was ready to finish the case. And I said, well, hang on a second, let me bring this over. And of course, he gave me that noise like, oh man, well, you're gonna mess my case up. I'm trying to get this done. So I said, oh, it's gonna be easy. We're just gonna put distilled water in the canal, taking this laser fiber tip, the 200 micron radial firing tip, put it in the canal, activate on the way out. So if nothing cloudy comes out, then it was clean. So you're saying, well, what am I going to see? I ran all the ultrasonics in there. So take a look. Take a look at what comes out. This is after ultrasonic activation. See this cloud of debris. So the question basically will be, how do you know you're done activating or irrigating for that matter? Well, if there's still debris or cloudy stuff coming out of the canal, you're not done. So you just need to continue. So we recently were kind of using this Merida erbium YAG. It's the same wavelength as the Photona laser. The Merida has tips that go down the canal. So we're this is a 300 micron tip, similar to the tip of a size 30 hand file. So this was an infected case. So we've instrumented, and now we're doing this final activation. So we take the laser fiber about mid-root, activating on the way out, and then take a look at what kind of comes out of the other canal. This is after full instrumentation and irrigation. So laser tips going in one. There's going to be activation as you kind of withdraw, and you're going to see pus coming from the other one. So when you kind of read the literature on this, they're talking about so drainage, yeah, for sure. So there's drainage from the periapical abscess that was kind of helped with the activation of irrigant in one canal. So I have to talk a little bit about myth busting. I've heard and I've seen and I've read some claims about lasers where you take the laser tip into the canals. And they're saying you have to be really careful because ledging occurs a lot. You can char or burn the dentin. Are you actually cleaning? What about extrusion? So this will go fast. The picture up here, the Nd:YAG in dry mode, right? So the Nd:YAG there, this was done dry, laser tip, right? Photothermal effect. And if you have the settings high energy, there's no liquid, you could easily cause charring or burning of the dentin. These pictures on the bottom, right? The one on the left is Nd:YAG. This one, which is the same as this one you see here, this was done with the Waterlase, radial firing tips. How is it possible that you can get this kind of charring effect in a canal, right? So this was an extracted tooth, you run your protocol, and then you split the tooth in half, and you see this incredible charring. So this was done dry. And it's like, the name on the machine is called Waterlase. We are not activating the laser, the erbium chromium YSGG in canals dry, right? So that will never happen. This picture that shows kind of like a divot or a ledge, we keep the laser tip in the mid root to the coronal part. The tip should never bind. It has to be loose. It needs to be water around it. So these issues of ledging and charring, we have not had ledging in kind of, it's almost 4 years now of using the YSGG Waterlase laser. And my residents, they're novice users. So there's a protocol, very simple, and it's extremely safe. So we did an extracted tooth, right? We ran the protocol, we split it, and you kind of see both halves, no charring, no ledging. So someone kind of criticized this and said, "Oh, you're trying to prove a point on a straight canal." I go, "Well, this is a straight canal that was shown with the charring." So one of my residents kind of took an extracted molar, instrumented it with a 2004, full protocol with the Biolase YSGG. We used the RFT3, the 320 micron tip. We bring it as far as it will go, so it will never bind. It has to be loose. And then we activate on the way out. We split that case, and no charring, no ledging. So this is fake news, if you ask me. And then if you kind of look at the literature, yep, from 2004, no ledging, no charring, and these were kind of extensive studies. So this collage is kind of like a lot of cases from my residents, cases from Francisco Banks, Jacob Pelka, Gary Glassman, and we're going to kind of go through some of these. So can you ledge if you're using this incorrectly, right? So some of the understanding will be the settings that we use, the energy, and especially, let's say, energy density, has to be appropriate for the job. So, and very straightforward, very easy. When we're in the canal and we're activating irrigant with one specific tip, radial firing 200 micron or the radial firing 320 micron, yeah, I'll show you what the settings are, and we don't really deviate from them. What we do pay attention to is how far down the canal can we bring the laser tip without it binding. And on some canals, we could only get it maybe in the coronal millimeter or two, depending on how severe the curve is. So this brings us to this point where the benefits of taking the laser tip into the canal been widely studied. One is it eliminates this vapor lock or airlock, and it does so without extruding any of the irrigant. We can get the irrigant to kind of get to the apical portion without extruding it. And this was done on patients. I'll show you that one. Studies have shown you could remove apical debris, smear layer, enhanced, improved cleaning of the main canal, lateral canals, fins, as well as kind of the antimicrobial effects, which have also been studied several times. So this is kind of a study on patients, right? 40 patients, single rooted teeth, open apex, all with periapical disease. So they took sodium hypochlorite, mixed it with a radiopaque contrast medium. This way you could take radiographs and you could see how far apically the liquid actually went. The Waterlase YSGG, 200 micron tip over the orifice, 60 seconds. And then the other group was the passive ultrasonic activation with an EriSafe tip taken 2 millimeters short of the working length, also 60 seconds. So what you see on these radiographs, this is not calcium hydroxide, it's not sealer, this is sodium hypochlorite mixed with, say, barium sulfate, a radiopaque material. And it shows you after the 60 seconds with the laser, you see the contrast medium, the liquid, all the way to the apex. With passive ultrasonic, it does not get there, right? So no extrusion of irrigant beyond the apical foramen in all groups, which is great. On the laser group, you see the contrast reached the apex in 20 of 20 teeth. In the passive ultrasonic irrigation group, it only was like in 50-50 of those. So I'm going to go through this one quickly. This is where the erbium YAG, the Nd:YAG, and the Waterlase YSGG were used to kind of disinfect or clean out biofilm that was grown in extracted teeth. So according to the guidelines of each device, the Waterlase, the 200 micron tip, was placed 5 millimeters from the apex, that's kind of mid-root, and it was compared to the PIPS technique and the Nd:YAG. And what's important and interesting is that no hypochlorite, no EDTA was used, only saline. So saline is not going to kill bacteria, but if you activate the saline or the distilled water and you create shock waves and cavitation and acoustic streaming and all these things, it's going to physically disrupt the biofilm, and it will have an antimicrobial effect because of the high energy that's imparted on the liquid. So the lasers did a better job. The Nd:YAG kind of did nothing, but the Waterlase, the BioLase YSGG, significantly more bacterial kill. So saline, why? So basically it's the photoacoustic effects, as I mentioned, in saline or in distilled water actually will disrupt biofilm and kill microorganisms. So why? Basically, it was because the tip of the YSGG was taken to mid-root. And so the positive effect is attributed to the mechanical disruption, the fluid movement. So makes total sense. I wanted to get to this before I show a bunch of cases and then some surgery. So there's actually an outcome study. This was a randomized blind controlled trial, teeth with apical periodontitis, dental students, and again, randomized trial. So the control group, right, you see here, instrumentation with hand files to a size 30, irrigating with hypochlorite, dry the canal, calcium hydroxide paste. Patient comes back a couple of weeks, calcium hydroxide removed, canals irrigated with 3% hypochlorite, and then obturated. Now, the laser group, no hypochlorite, no inter-appointment calcium hydroxide. Same type of instrumentation, size 30. Canals were filled with distilled water. The laser tip was taken deep into the canal, activated on the way out, 2 times per canal. Canals were dried, laser tip brought down, activated. Second visit, right, so then the teeth were closed with a cotton pellet with like a crescifine stuff. Second visit, again, no sodium hypochlorite, canals enlarged 1 more size, irrigated with saline and laser activation, just like the first visit, right? So now they're following these cases for a year. And what you see here is that the conventional group, hypochlorite, calcium hydroxide, yep, improvement 75%, really good. The laser group using only water, 83%, but there's no statistically significant difference between these two groups. So this is like a non-inferiority study. So what they're saying is that the laser YSGG wavelength only with water was as good as 2-visit treatment, same instrumentation using hypochlorite and calcium hydroxide. So non-inferiority, and this is a very, very good outcome. So it's not only about outcomes. And I'm saying this because to get the perfect or the really high level outcome study that people will kind of believe is good, you're going to need a lot of teeth. You're going to have an 80% recall rate over a period of 2, 3, 4 years or more. It will almost be impossible. We're not going to see it with laser. We're not going to see it with gentle wave or photo-activated disinfection. Really difficult. But what the laser use will do, and this is kind of what I've seen with my residents for 4 years, is that when you're activating in the chamber, as soon as you complete your access, you get a better visualization of the color map, lets you find canals. It's not going to all of a sudden enlarge canals for you. The canals where it's difficult to get instruments to get to patency or your working length becomes easier with the laser activation of irrigant in the chamber. So it simplifies the endo procedure, and I see this especially for grad students, my residents. It will, as the studies show, help with debridement and disinfection. And then the benefit of this wavelength, the BIOLASE I plus YSGG, we use this all the time for soft and hard tissue procedures. It is just fantastic. The hemostasis that you get with the YSGG wavelength is far superior to what you get with erbium YAG. And we have erbium YAG. And when we're doing surgery, it's like, no, I want the BIOLASE I plus for this. So you use your whatever technique, whatever instruments you use them. This is agnostic to the file system you use. So step 1 with laser activated irrigation, you complete your access. Obviously rubber dam, we have blockout around it. We're using a 500 micron tip. This MZ5 is the name. We keep it in the chamber above the floor, and it's 1 watt, 20 hertz, which is 50 millijoules. And we're going to do it 30 seconds with water coming out of the unit. When we can kind of have an assistant be right there, we'll turn the water off and we'll have continuous hypochlorite being squirted in. So this top picture here, you see the laser handpiece. This is the laser fiber. You have green opal dam around the tooth, and you see this is the needle of the syringe, 90 degrees, so it's kind of can sit right against this wall. And this blue thing that you see on the upper right is a saliva ejector. So you can have someone squirt hypochlorite into the access cavity while you're running this laser 30 seconds, take a look, 60 seconds, take a look. When it's clean, that part is done. So this is kind of a before on the left, after, let's say, probably 60 seconds of cycles with hypochlorite, you kind of scoop out some of the hemorrhagic tissue. Now you see that the chamber's pretty clean, free of debris. And if we need to adjust the access with ultrasonics or Munzbur's or whatever, it's much easier. Same thing with this one. Caries removed, defective restoration removed. You see all this debris here. So 30 seconds, 60 seconds, you see what's on the right. A much better visualization of the color map, dark floor, light walls, and you kind of see where the orifices are. And you just kind of want to get rid of some of the calcification there. So as we're instrumenting, we're using step number one, the MZ5 tip, right? Same setting with either water through the handpiece or with hypochlorite. So we have to each instrument 10, 15 seconds over the orifices to blast out the debris. We're going to suction the chamber, fill the chamber with hypochlorite, and continue to instrument. So this part is basically to really blast out the debris that the instrumentation causes. And why we suction and then put hypo in, well, I want to do all my instrumentation in the presence of hypochlorite. Continue the instrumentation until you're all done. So now, instrumentation is complete, you're done shaping. This is our final irrigation disinfection protocol. So we're going to be using one of these two tips, the radial firing 200 micron tip or the radial firing 320 micron tip. Again, depending on the canal anatomy, somewhere mid-root, halfway down, or in the coronal third. If we're using the RFT2, right, the skinnier one, size of a 20 hand file, it's glass, it's little flexible to get in. We kind of place the tip, activate on the way out, and on the way out, we'll keep the tip in the orifice, activate for 30 seconds. And again, this will be with hypochlorite being squirted into the chamber. If we're using the 320 micron tip, the radial firing tip number 3, this one, because it's a little bit wider, we lower the settings that you see here, 0.75 watts, 50 hertz, 15 millijoules. We can keep this tip in the coronal portion, kind of move it up and down very slowly, 30 seconds. So what you see down here, this is kind of a final irrigation protocol that we adopted from Olivi, right? Wrote this book, Lasers and Endodontics. So hypochlorite, 30 seconds per canal. And what we typically do is in that 30 seconds, we're squirting in 6 ml. So we use 12 ml syringes for hypochlorite. Half of it goes in one canal during the 30 seconds. Then EDTA, 30 seconds per canal. And then a final hypochlorite activation, 30 seconds per canal, again, 6 ml. And then final rinse, we turn the air and the water on. We bring the laser tip again, mid-root, coronal third, 30 seconds of activation of the distilled water to kind of rinse out any of the chemicals that are there. And if it's still cloudy, you need to do more. So it's the canal is telling you you're not done. So this is kind of just a schematic of what we're doing. You kind of see here at the end of instrumentation, hypochlorite, 30 seconds per canal, EDTA, 30 seconds per canal, hypochlorite, 1 cycle or 2 cycles, 30 seconds per canal, and a final water, right? And the settings, right? You have the setting and you don't change it. So I did a 1-day course at Fort Liberty a few weeks ago. This was the first case done after my course by a first-year resident on this premolar. I mean, this is like spectacular. So this is a very easily transferable, easy to learn protocol, right? So you kind of are doing your endo, you're activating as soon as you're done with your access. When you're done instrumenting, you're activating a very specific protocol, and you get some really, really beautiful results. So I have a couple of cases from Charles Maupin. He's been using the Waterlays, YSGG, I think around 6 years. We have 4 years in my program. So I learned a tremendous amount of technique, understanding the simplicity of the YSGG laser, and his cases are really beautiful. And Charles uses Kerr EWT sealer. So it doesn't have to be high flow, it doesn't have to be bioceramic. It could be a ZOE, it could be AH plus, or any of the bioceramics. This kind of bizarre looking C shape, it's like, yeah, this is really beautiful. So you're getting so much tissue, debris, biofilm out. So now when you have sealer that goes in, and this is not deep warm vertical, you can't get pluggers anywhere there, you begin to see like much more complex anatomy that's being demonstrated by sealer. This kind of resorption case, again, per EWT after laser activation. So all of the tissue that would be in these resorbed areas, yeah, not easy to get out, but you're taking advantage of the cavitation, the shock waves, the acoustic streaming, the shear forces of the liquid, right? Of the liquid to kind of disrupt, blast out this debris. Gary Glassman's case, he just sent this, right? So this is like a mid-distal thing. Yeah, that wasn't instrumented. So it's really the photoacoustics as you're instrumenting and irrigating, your final irrigation thing is it's breaking up, it's disrupting, it's dislodging, it's getting this stuff to kind of float coronally. So you hear the term laser patency. So what does this really mean? So if we can't get hand files to patency or whatever your length is, right, we have just a little easy protocol. So you're going to shape the canal the way you normally do, just short. Obviously, you're blocked or there's a ledge, you can't get past it. So we bring the radial firing 200 micron tip, just short of that. We're going to activate as we withdraw. And this is that same setting, 1.25 watts, 50 hertz. And we're going to do it with air and water, right? Very standard setting. And you do this several times, and then you're hoping you get lucky, like on a lot of these cases. Anytime you see Einstein, it's one of my residents' cases where you could not get mechanical patency. So, yep, you have to stop fighting at some point. So you're going to shape the canals, you're going to activate your irrigant with that final protocol, and then you're going to fill the case. And then, yep, if the sealer goes, it goes. It's certainly not gutta percha that's going in these areas. So this is a case 6-month follow from one of my residents. You see the PAs top and bottom, the sagittal and coronal slices. You have really good healing here at 6 months. Rob Cord just sent this case pre-op. It's a retreat of this tooth number 19. Waterlays, YSGG throughout, final activation protocol, 6-month follow, really good repair. Case from one of my residents, yeah, very dangerous looking C shape. So we're not taking the tip into thin isthmus areas. You'll just be asking for trouble. If we can get that 200 micron tip in the coronal third where it's loose, right? It should never bind. And we're going to activate as we're going, final activation protocol. And then this is modified single cone. And you kind of see on the post-op cone beam how really beautifully the sealer was able to get around the C. Is it completely clean, 100%? No. Is it 100% disinfected? No. Is it better than what we can do with anything else? Without a doubt. There's no question in my mind. So this really intricate looking case by Rob Core, he sent this one. Long, skinny roots. And when you see this picture here, lower right, the laser tip is staying just in the orifice on this one, right? You're not bringing the laser tip. You're not even bringing your rotaries around here. So this is activation of your hypochlorite, several cycles to disrupt and break up this tissue. Fernando Mesa's case, he used that MZ5 in the chamber and then in the orifices on the C shape. Case from Francisco Banks, and he's another endodontist who I learned a tremendous amount from. Complex, crazy DENS anatomy. BIOLASE YSGG protocol, a lot of activation with hypochlorite and a 1-year follow, significant healing. Is fully healed? No. I'm pretty sure it will be, but look at the complexity of the anatomy where the BC sealer was able to go after the activation and agitation with the laser. Charles Maupin's case, 2-year follow, the cone beam shows significant bone loss. Kind of see this with the orange arrows. 2-year, yep. Tremendous healing on this case, tremendous. And the YSGG throughout the entire procedure. 2-year follow-up on a 1 visit from Rob Core. Look at this on the cone beam. I mean, it's like more than likely, we probably wouldn't get a case referred to us like this. If the general dentist had a cone beam, they probably would take this out, look to do grafting and then an implant. So 2-year, look at the healing. Reestablishment of the plate of bone. This was probing to the apex. This defect, for the most part, completely healed. Jacob Pelka, former resident of mine, BIOLASE, and like, where you going with your hand files here? You're never getting them around here. So activation of your irrigant, and you do the final protocol. If there's still anything cloudy, you're going to do another 30 seconds or 60 seconds. Obturate the case, BC sealer, single cone, if you can even get cones in, and the 2-year follow-up looks fantastic. The post-op is fantastic. So this is the same case, PA, and this is the sagittal slice, 2-year follow-up, sagittal slice, and the PA. So you see this significant healing on this case. And when I thought I saw as crazy a case as I could imagine, Gary Glassman sends this case, posts this case. Look at these curves. So these yellow arrows are kind of showing this is where the instruments stop. And yeah, if you are determined to get a file, a 6, 8, or 10 to patency, good luck to you. You're going to kill the case. So he shaped to where he was able to shape, ran the YSGG protocol, right? Activation of hypochlorite, EDTA, hypochlorite. And the post-op is amazing. 3 months and 18 months. So it's kind of unbelievable, actually. So I'm kind of a little bit over, but bear with me. So the soft tissue component, pulpotomy, gingivectomy, osteotomy, all easy, all very doable. So this is kind of a video. We get a lot of young patients, tons of caries, clean the caries out. We're into the pulp. So now we're doing pulpotomy, right? Vital pulp therapy. So instead of using high-speed diamond or a round bar, we're using the MZ5 tip or an MZ6 tip on a pulpotomy setting to ablate the pulpal tissue, not with heat, but with water spray. So we're taking advantage of the chromophore, which is water. There's water in tissue, of course, that absorbs the energy, and then layer by layer, whether it's gingiva or in this case, pulpal tissue, is ablated away. We do this, we kind of look at it. We want to see that we have hemostasis there. If you see bleeding, we kind of come back with the laser, do another 10 seconds, 15 seconds, or whatever. We dry these always upside down paper points to dry. Looks great. Now we're going to put BC putty or Biodentin there as the pulpotomy material and restore. This was a SPECT partial pulpotomy. Young patient came in, complicated crown root fracture, exposure. This again, MZ6, water lays with water. We're not trying to cauterize or use heat to stop the bleeding. You do this, you get down to a level, pulp tissue looks great, BC putty goes in, and we restore. So you would wonder why is an endodontist or an endo resident doing gingivectomy? Well, this young patient, abysmal oral hygiene, gingival overgrowth, very, very deep labial caries. So you could use a diode. Some people use a System B called System Barbecue to get that off. That's a lot of heat, and the healing is a little bit tough. So we're using water lays, right? MZ6 tip, gingivectomy setting, always with water. What you don't see, and you should ask, why is there no bleeding? Because the penetration of this particular wavelength is 3 times deeper than erbium YAG or the Fotona. So you get beautiful hemostasis as you're doing this, right? So you're kind of layer by layer, you're taking this away, very controlled, very precise, because you are seeing through the microscope exactly the amount of tissue that you want to remove. So this is a palatal surgery of an cervical resorption, incise a palatal flap, reflect it, and now we're going to be removing all that hemorrhagic granulation tissue that's in there. Yeah, and you get amazing hemostasis. We're going to remove some bone, so we have margins where we could then restore with composite. This is a flap created with the YSGG laser. This is a tapered tip. Francisco Banks sent this to me. He's very happy, and he says he has been scalpel free for several years. So you can use this to incise the flap. Right now you reflect. You're going to use that MZ6 or MZ5 tip to kind of cut a groove in the bone so your periosteal can go there. This is a chisel tip, which is great for sulcular flaps and papilla sparing. So right now, there's a groove being cut for the retractor. You're using this laser tip, right, really fast, to take away the bone. You're kind of painting the bone away for the osteotomy, and then you can do the root resection with the same exact tip, just a different setting. So this is one of his surgeries, and you see a 1-year follow-up, full bony healing. This is one of his cases where you have this resorption on the labial, elevate a flap, you clean the resorption out. He did the root canal. Thank God you have controlled memory files. You'd never be able to do this. Does the endo through there, kind of amazing. He's a fantastic clinician. And then post-op with sutures, 1-year follow-up, everything looks great. So again, it's not just about outcomes, it's about finding canals, simplifying the procedure. And if you do soft and hard tissue procedures, you will love the YSGG wavelength. So this is my gang that some of them graduated. Steve Nimzig, you see here, Bruno Azevedo, Ben Schwab, Tony Chen, and Julie Brandt. This was Halloween, so may the force be with you all. The laser adjunct for endodontics is just fantastic, and it's like, yeah, you cannot go back. I couldn't imagine ever not having a laser to treat patients in our grad program. So thank you all very much. If there are questions in that queue, Joe, you can kind of take it from there.
Yeah, for sure. And Dr. Barnett, fantastic information. I want our audience to take note of your email address there, since you were so kind to put it on the last slide. Good news, bad news. Good news is fantastic lecture and great information, great cases, especially there at the end. Bad news is we're out of time. So we ran out of time here. So I want to make sure if the audience has burning questions that they want to address with you, Dr. Barnett, they can ping you through your email there. We also have a BIOLASE education email address. So if to our audience, if you hang on just for 2 more minutes, I'll give you some information on how you can reach out to the BIOLASE education team. You know, we're in contact with Dr. Barnett as well. And we can make sure that, you know, everyone gets their questions taken care of. Just give me 1 second. And education.biolase.com is our education website. Okay, so to our audience, if you need more information about what we have available on the education side of things, go to education.biolase.com. I will say, you know, the questions that I saw pop up during your lecture, Dr. Barnett, since you were so thorough in the content that you presented, I'm pretty sure that the questions I saw were addressed in the information that you shared. Again, if that's not the case, please reach out to Dr. Barnett or our BIOLASE education team. You can go to our BIOLASE website and you have education, you have resources where you can find video content, and if you're a current WaterLase user, maintenance and service information, all sorts of information and resources in education. You can find clinical resources, clinical information, and course information. There's also a research article area. Dr. Barnett did a great job showing evidence-based information. If you want more information about some of our research articles about our YSGG technology, you can go to biolase.com and find that. WaterLase Academy is our education resource for YSGG. So I mentioned earlier that Dr. Barnett is instructing a course. I think I made a mistake and said it was in Dallas. It's actually at our home base in Orange County, California. We have a beautiful training facility there. And Dr. Barnett is going to be teaching an advanced endo course on WaterLase on July 19th. So if you want more information on that, you can go to that WaterLase Academy education area of our website, click on classroom trainings. You'll see his course, you'll see our foundations course, perio course, pediatric courses, all sorts of content in there that you can check out to further your education. Now, our next webinar is coming up in about 3 or 4 weeks, focused on hygiene and focused on diode lasers. We have a great speaker named Lynn Atkinson, who's a leader in the hygiene laser world, and she's going to be speaking on how to implement diode lasers into guided biofilm therapy. It should be great content. We're partnering with EMS on that webinar. So to our audience tonight, we would encourage you to join us on May 31st, excuse me, May 21st. To get your CE tonight, you must be officially registered. Attendance will be recorded via Zoom. Just please look out for a survey. You're going to get a survey via email about the lecture and Dr. Barnett and the content that he shared. You have to complete that survey, and then you will receive your CE certificate. So that's the key point to take away from that. You know, if you want more content, you can check out our webinar library, as I mentioned there at the very beginning of tonight's session, biolase.com/webinars. That email address I wanted to share to the education team here at BIOLASE is education@biolase.com. So feel free to email us. Again, to Dr. Barnett, thank you so much for the time and effort and passion that you have in laser technology. And to our audience, thank you for spending the last hour or so with us. I hope you have a great rest of your evening or day, wherever you may be tuning in from. And we hope to see you on our next webinar on May 21st.